Hi everybody, I'm Katie.
I'm Deb.
And we are so lucky this week to have Associate Professor Massey with us talking about clinical deterioration. Alright, so this week we're going to have a chat about clinical deterioration. We're very lucky that Deb's been able to put some time aside. I have trouble pinning her down for a coffee at times. She's very busy, so thank you, Deb, for doing that. Deb, can you tell us and tell people out there, why are you so passionate about the signs of clinical deterioration?
All right, thanks, Katie. I love to talk about deterioration, so you might have to stop me. But I suppose
that'll do.
Yeah, I suppose my journey into clinical deterioration, not literally, but theoretically, began when I was working at Oxford Brookes, and I started to realise that a lot of patients who would have been traditionally cared for in critical care areas, ICU and HDU, were now being looked after on the ward.
Yep.
And so I thought, well, there's a need really to develop ward nurses' skills in caring for not necessarily critically ill patients, but patients who were acutely ill. So when I was at Brookes, I developed a high dependency course. And then in 2006, when I moved to Australia, there was no high dependency units here.
Okay.
But what I did notice was that still patients were very sick on wards, and that there was a gap in particularly postgraduate education, but particularly in knowledge around recognising and responding to deterioration. And I think I feel so strongly, because I think it's a nurse's role. If we can educate nurses around the signs and symptoms of clinical deterioration, we can save patients' lives. And for me, that really hit home, and it was my journey on my PhD, because my PhD was in recognising and responding to clinical deterioration, was when I listened to Helen Haskell talk about her son Lewis, who was 14 and went into hospital for a routine procedure on a Friday. So it was the perfect storm. Went in on a Friday, minimal staff, over the weekend, exhibited all the signs of deterioration: pain, tachypnea, tachycardia, hypertension, deteriorating level of consciousness, olguria, and all those signs of deterioration were ignored, and he died. And he died of a perforated duodenal ulcer because he had an adult dose of a non-steroidal. And one of the key messages that Helen said that really hit home to me was the worst place he could have been was in hospital, because if he was at home, I could have put him in an ambulance and got him the care he needed. So for me, that, I had a 14-year-old boy myself, and I just thought, how awful would that be if that was my son? And I sort of started a crusade, I think, then, to really educate ward nurses, and actually all nurses, about the importance of assessment, because I think that lies at the heart of deterioration. Good assessment skills. And for ED nurses, that's so important, but it's so important for any nurse, whether you work in aged care, whether you work in the community, whether you work in ICU, whether you work in ED. We owe it to patients to have good assessment skills.
The respiratory rate is not 18, and if it is, check it again.
That's correct.
All right, Deb, are you hungry?
Always hungry, Katie.
Great. I'm going to go and cook us something absolutely delicious.
Carb-free.
It is
vegan.
It's definitely not. No, it's definitely not vegan, but it can be vegan adapted if you need it to be. So I'm going to pop off and cook that. While I'm gone, do you mind telling the audience how it is that you got to be Associate Professor Deb Massey this day?
All right, Katie's given me 2 minutes to talk about myself, which is quite an undertaking, because I love to talk about myself. But I did once win the 3-minute thesis, so it can be done. So I qualified in 1860. I know, you'd never believe it. But I qualified in 1984 in the good old apprenticeship model. I did hospital training, which I don't think is better than a degree. And then I went straight into cardiothoracic nursing, and I really stayed there for the whole of my career. I worked initially on a thoracic ward, then a cardiac surgical ward, and then I moved into cardiac ICU. I then set up the first cardiac recovery unit at Papworth Hospital. I did my cardiothoracic course at Papworth Hospital, and then I moved to the John Radcliffe, where they were really pushing the model of recovery for cardiac surgical patients and developing a much more nurse-led centre where nurses had extended skills and scope of practice. And there I did my master's and my degree, and then my teaching course. And then I started to move more into education, and I realised that there was a need to educate nurses, particularly around those assessment skills. I did a nurse practitioner course, a master's nurse practitioner course, and then from that moved into education at Oxford Brookes, and led the critical care courses at Oxford Brookes. And then I worked there for about 8 years, and then I moved to Griffith, where I did my PhD and worked in the undergraduate courses. After my PhD, I'd had enough of research, teaching, students, everyone. So I went back to practice for a couple of years, but actually missed students, teaching and everyone and research. So I went back into university setting, and now I'm the head of nursing at Southern Cross University. I still work clinically, I work in ICU, I do casual shifts, I still teach in areas related to the deteriorating patient, and I've got a number of PhD students and HDR students.
So I made lunch, and you just have to take our word for the fact that it was delicious. Because we were so hungry, we actually forgot to film it. So I apologise. Please refer to the cooking video. Deb's fully satisfied now with her fajitas that she's had.
I would have preferred Otti Lengi, but
I'm not fancy enough. She's a little bit fancy. I'm trying to keep it easy for shift workers. They can't do 46,000 steps to make roasted potato. Yeah. So we're going to talk now about Deb's amazing 10 signs or 10 top tips for clinical deterioration.
All right. Well, I think the first, and I'll try and relate it to ED, because
Okay.
I think these 10 people who tend to watch this tend to be ED nurses. So I think the first thing that I want to say is recognising and responding to patient deterioration is not rocket science. It's easy, actually. It's very straightforward. But we know that nurses don't do it. We know that they don't do respiratory rate. We know that they don't count the respiratory rate. We know that they don't assess patients properly. And the reasons for that are complex. But for me, the biggest thing is, and this is my top tip too, we need to embrace the vital signs and we need to chuck out the obs. It concerns me that we delegate what I think is the most important element of a nurse's role, assessing your patient, to the most uneducated, poorly, probably unsupported members of the team. And I really think we need to embrace vital signs and make them great again, in the words of Frank Seabat.
Make vital signs great again.
Chuck out the obs, that's mine.
Yep.
Frank Seabat's, make vital signs great.
Okay, I like that.
Yeah.
I like that. So when we're taking a respiratory rate, do you stand by the fact that we should be taking it for a full minute?
Yeah, and actually when I was talking to, because I talked to Frank Seabat, who actually wrote a paper called The 10 Signs of Vitality, He says you should listen with a stethoscope.
To the respiratory
rate.
And
count it. There are increasingly some apps coming out, tapping apps that also help respiratory rate. But for me, I tend to sit and count, put my hand on the chest and count for 1 minute.
Because it's also that moment to build rapport with your patient as well. You're holding their hand, you know, the old thing is that you pretend that you're taking their pulse and you hold their hand across their chest and you awkwardly look away for a little bit and just say, I need to concentrate. But it's building that connection with your patient as well.
You can feel them. You can feel the rise and fall. You can feel if they're hot, if they're cold, if they're sweaty.
Yeah.
You can look at them. Are they cyanosed? Are they peripherally shut down? Do they look distressed?
Yeah. Great. Number 3. What would you say is number 3?
Well, number 3 for me would be learn some key systems. So learn how to take a good respiratory assessment. And when I went back to practice not long ago, someone said to me, why have you got a stethoscope around your neck? And I said, to listen to a chest, patient's chest, not any chest, a patient's chest.
But you're not a doctor.
Yeah, and they said that. And that also concerns me because, you know, that patient that I then went and listened to, you know, I took a handover from a patient who had a respiratory rate of 18, who had a blood pressure of 110/60, who was... heart rate was, 80. But when I did the respiratory rate, it was 33. When I listened to the chest, they had bilateral crackles. When I did the blood pressure, it was still 120/60. The heart rate was still the same, but they were beta blocked. And the patient was in left ventricular failure and needed BiPAP and needed IV dobutamine and IV Lasix. So you do need to be able to listen to chest as a nurse. You do need to do a respiratory assessment, and it starts with the respiratory rate, and then inspect your patient, palpate.
You mean undress your patient?
Inspect.
You mean actually put them in a gown and
okay. Look at them.
Yep.
Yeah. So I think learn some good assessment skills for the key systems, particularly in that ED setting: respiratory, cardiac, abdo, and probably musculoskeletal.
Yeah, definitely. All right, number 4.
Number 4 would be remember the skin's the biggest organ in the body, and as such you can learn a lot from inspecting your patient. I think we underestimate the importance of inspection, and we just rush in and wrap that blood pressure cuff around a patient and then press a button and walk away.
Yeah.
And so I think you need to look at your patient, look at their skin. Are they cold? Are they warm? Are they peripherally shut down? What's their pallor like? Do they look like they're cyanotic? Do they look like they've got peripheral cyanosis, central cyanosis? What's their hair distribution like? Is it unequal? Are they hairy?
Yeah.
Have they got, very fine hair? Does that tell you that there might be something happening with their thyroid? What are their nails like?
Yeah.
Have they got clubbing? Have they got brittle nails? Have they got, the nails where you've got the white line, Terry's nails, I think, might indicate they've got renal failure. Have they got green fingernails, which might tell you that they've got an infection? So you can learn all that from just looking at your patient.
Yeah. Alrighty. Whew, so much to take in. I love it. All right, number 5.
So number 5 would be to, and it's sort of linked to all of these really, they're all linked. It would be to embrace and use the 10 signs of vitality that Frank Seaback talks about. So 2 people that I use a lot in my practice, but also when I teach, is Frank Seaback and Clint Douglas.
Yep.
And for me, they're like a toolbox that nurses should use when they go and assess patients. So rather than just taking temperature, blood pressure, and respiratory rate, we need to be taking all of that. Thinking about all 10 signs of vitality. Yeah. So the 10 signs of vitality, I think anyone can do them. Again, it's not rocket science. It's fairly easy. Respiratory rate, the number 1. And the number 1 sign that your patient's deteriorating. If your patient is not tachypneic, they are not deteriorating. It's that simple. So tachypnea or respiratory rate. Number 2, heart rate. Obviously an important vital sign. Number 3, and probably the second most sensitive indicator that your patient's deteriorating is level of consciousness.
Okay.
So assess your patient's level of consciousness.
And it doesn't need to be a GCS.
It doesn't.
It just needs to be an AVPU.
Yeah. But actually, I think that's probably one of the next signs I would talk about is areas for future research. And I think level of consciousness is something we could look at a bit more, because we haven't got a validated tool to easily assess level of consciousness, because Glasgow Coma Score is notoriously tricky. It's not difficult, but I could do a Glasgow Coma Score, you could do it, and we could actually interpret it a little bit differently. So although it is good for level of consciousness, it's not necessarily good for sort of delirium and those other things that you might see in a patient who was deteriorating. But having said that, changes in level of consciousness is the second most sensitive indicator that your patient's deteriorating. And that the next sign of vitality that Frank Seebat says that actually if you do respiratory rate, level of consciousness and capillary refill.
So this was the paper that you sent me recently.
You don't need to think about anything else. If they're all normal, your patient's not deteriorating. How many people do a capillary refill?
Very few, but everybody ticks the box.
And so, he's done a really nice paper that says if you rely on capillary refill and level of consciousness in the presence of sepsis, you actually will give the patient less fluid and the patient will do better. So if you're using lactate and level of consciousness and the other vital signs, you tend to give patients fluid more and they tend to do worse.
Right.
So the capillary refill is an important vital sign that I don't think we utilise as nurses very often. The next vital sign that I think we need to think about is pain. And I remember the great and wonderful Julie Constantine, I went to a lecture she once said, and she said, when your patient's in pain, they're trying to die and you're not doing anything about it. So, and I always remember that.
I love how blunt she is.
Because, I think we can say, oh, well, they're anxious. Or, they've got a low pain threshold.
We can always come up with a reason. Oh, they're iPhone positive. Doesn't mean that they're not in pain. They're using destructive therapy in order to deal with their pain.
And that's and that's what she said. They're not anxious. They're trying to die. Pain is a physiological response. And actually, when I talked about Lewis, and I think if people are interested in that, they should just Google Helen Haskell and listen to her talk.
I'll put some links on the page.
But that was his first sign. He had abdominal pain. And they just kept saying he's got wind, he needs to mobilise. And so his first sign of deterioration was pain. And I always say now to any student I teach, pain's the fifth vital sign. And if your patient says they've got pain, you don't dismiss it, you assess your patient for why that pain is there. So pain is the fifth vital sign. Urine output, obviously. So,
not very well measured.
No. And again, I think the NICE guidelines say that we need to be much more strict with fluid balance.
Precise with fluid balance, yes. It is something, and I'll admit as an emergency nurse that I am horrendous at fluid balance. Like I am. Because there's so many competing interests for my time, and that's no excuse not to do it correctly at all, but I do find that there's so many other things going on with your patients that are undifferentiated that you don't always realise how vital fluid balance is for your patient's outcome.
So I think obviously urine output, but also not just like measuring the urine output, but looking at it, looking at the colour it is, even is it how difficult it is if your patient is not incontinent or is able to, what's the word I'm looking for?
Is able to have some flow, is able to wee.
Continent is the word.
Is continent,
Then, how easy is it? Have they got hesitancy? Is it difficult? So I think urine output is an important vital sign. Oxygen saturation, obviously linked to the, your respiratory rate. Bloods, Frank Seebat talks about, using the venous arterial.
Which we use a lot. It's very rare that we put an art line with our critically ill patients in emergency, but it is so easy to pull off a venous gas.
But even if you're not in ED and you're a ward nurse, or say you're working in somewhere that you might not have access,
Yes.
you can still look at bloods, still look at what their CRP is, still look at their full blood count, still check if their troponin's up. So for me, it's not just that. It's not just the venous arterial. It's
There's so much
blood.
more to the story.
Yeah, it's the whole blood picture, if you like, and checking that.
So for those newer nurses, you recommend that they go through the blood results and start to pick up if you've got an abdominal pain that has something really wrong with them, that you're going to see, potentially a raised CRP. You might see a bit of a lactate raise and things like that, and start to put the story together for your patients.
Or if it's someone who, I don't know, has come in with maybe a decreasing level of consciousness or central chest pain. Let's say central chest pain. What's the troponin level?
Yeah.
If they have come in with changes in level of consciousness, maybe have a look at are they on warfarin?
Yeah.
Have a look at their platelets.
Yeah.
So try and link it to the sort of underlying condition that the patient presents with as well.
Yeah.
But having a full picture of that patient's blood.
Yeah.
And not just leaving it to the doctor.
Yeah. It's not just the doctor's responsibility.
No, it's not. No. And then where were we up to?
9.
So, up to 9. And then
6 in that, but 9 in that.
So temperature.
Yes.
And actually temperature is, everyone does temperature.
35.9.
Yeah. But it's a poor tool to predict deterioration, actually.
It really is, yes.
It's probably the least useful tool. And when you talk about SIRS and Q-SOFA, and you think, and sepsis obviously is, very out there at the moment. Everyone's talking about sepsis. Yeah, it's trendy. But actually, in terms of your sepsis picture, it's a poor predictor for deterioration. So we should do it, but actually, a patient who's hypothermic is probably more at risk of deterioration than someone who comes in with a temperature of 38.9 or 38.5.
A lot of the departments I work in as well, we've got 4 different types of, ways of taking a temperature. We can scan their head, we can roll it across, we can stick it in their ear, we can stick it under their arm, we can stick it in their tongue. There's no consistency depending on the area and what tool is actually available to you to take the temperature. So, there's a bit of a fault in the system there. It's a glitch in the matrix.
And I can't remember what number 10 is.
It's all right.
Of the 10 vital signs, but I'm sure you'll put a link up, or I can give you
you know what? We're going to start a conversation where you guys tell us what number 10 is, please.
Yes.
So we'd love to hear from you. What do you think is the 10th vital sign? All right, let's go back to our top 10, not of vital signs, but of things for clinical deterioration. We're up to number 7.
So number 7, I think, is listen to your patient and or the carer.
Yep.
And I think increasingly again, Lewis's pet mother, Helen, said to those doctors, Lewis is deteriorating, and she wasn't heard.
Yep.
And so I think, and there's a lot of evidence, there's someone doing some research in Leeds that says if you ask patients and their carers whether they're feeling worse or better, how are you feeling today compared to yesterday? If they say they're feeling worse, that's a big predictor that they're going to deteriorate.
Okay.
So I think listening to patients and asking patients is an important part of your role as an ED nurse, but it's also an important part of any nurse's role in recognising and responding to deterioration.
Number 8.
So number 8 would be learn to hand over your patient using a structured framework.
Oh. How many times? And have the patient, the person that's caring for the patient, hand over the patient. There's so many departments that I work in where the team leader's handing over the patient and they are so far removed and they're handing over to the team leader, not nurse to nurse looking after the patient, and it's an irk.
Yeah, and I think, there's a lot of literature out now that using S-bar or IS-bar or whatever tool you use, but using a framework, a structured framework, really does influence patient outcomes and makes a positive contribution to patient safety. And I will tell the students when I teach them, the doctors are busy and the senior nurses are busy, and who's going to get their attention of the doctor if you ring up and say, can you come and look at my patient? They just don't look right. compared to someone, can you come and look at Mr. Smith? He came in yesterday with central crushing chest pain.
Yeah.
His pain's now 8 out of 10. He's tachypneic at 25. His blood pressure's 105 over 60. He's oxygen saturation's 90 on 4 litres.
You're giving them a story.
Yeah, he's not past urine. Yeah. I want you to come and look at him and see and assess him, because I think he's deteriorating.
Yeah.
Who's going to get the best attention for their patient? The person who says, can you look at my patient? They just don't look.
Yeah.
Right.
From the end of the bed, they look quite unwell. Yeah. Like, you've got to remember, I'm working in a position at the moment where I've got to put together a clinical picture over the phone. And it's really difficult, and it's been a really big step for me, because I can't see the patient, I can't touch the patient, but I need to rely on the story of the person at the end of the bed. And I often say to them, what do they look like from the end of the bed? Do they look unwell, or do they look okay? Alrighty. We are up to, is it 9?
Number 10.
10! Sorry, at least someone's paying attention. Alright, number 10.
So number 10 would be to, I suppose it's a bit of a call out to make sure your practice is based on evidence and is research based, but also to identify where the gaps in knowledge are around that patient deterioration.
You don't know what you don't know.
Yeah. So I think, I was talking to someone last week about where the gaps in knowledge are in patient deterioration, and you might think, it's all been done. We know about early warning scores. We know respiratory rate's the biggest predictor that the patient's deteriorating. We know that we don't really do respiratory rate. We know that rapid response systems help. But what don't we know about deterioration? And he said to me that probably one of the biggest areas would be around respiratory and oxygenation. He says, how many times do we just put 4 litres of oxygen on a patient? Where's the evidence for that? What harm are we doing? What type of oxygen should we put on?
Yep.
How should we best measure respiratory rate? Should we stand and count for a minute? Should we use technology? Should we, listen with a stethoscope? Yeah. There's a lot of work to do around that changes in level of consciousness. We haven't got a validated tool to assess changes in level of consciousness from a deteriorating perspective. We have for level of consciousness the Glasgow Coma score, but not necessarily specific to deteroration. So,
would you say that further research is required?
Yeah. And I think for me as well, I think there's something to do around that capillary refill.
Yeah,
I don't
definitely.
think we do it.
Yeah.
And I think there's more and more to be done in specific populations. Like, I'm doing some work on maternal deterioration.
Okay.
So, I think we can say, patients who are on gen med or gen surgical or in ED are at risk of deterioration. Well, yeah, they are, but so is a patient perhaps who's in a mental health setting.
Yes.
Or in aged care.
Anywhere throughout any health facility.
But they may have different physiological responses. If you're pregnant, you may have a different physiological response to deterioration than a 90-year-old coming in from an aged care setting, than an 18-year-old who's, had a car accident.
Yeah.
Physiologically, you're going to respond differently. And I think we perhaps need to move down that sort of area. And then I think finally the other thing, linking all that to that research, is that Darryl Jones talks about the epidemiology of adverse events and MET calls, and I think there's something to be said there, that we know that the reasons why rapid response systems are called as for sepsis, hypoxia, and changes in level of consciousness and arrhythmias. So we should be developing bundles or packages of care for those adverse events, so that we can actually escalate and manage deterioration better
and quicker.
Yeah.
Without the cognitive load that clinical deterioration brings upon the clinicians. Okay. Well, there is a lot of work to do, that is for sure. Deb, I'd really like to thank you for putting time aside.
Thanks for having me, Kate.
That's
it's
all
been
right.
a pleasure.
She'll be back for part 2. She loves a natter, and I'm sure she'll come back and have another chat with us about some of her passion areas that she's got at the moment. So again, thanks, Deb.
The angel and hero narrative.
And we are not opening that can of worms today, but I'm sure that we will open it in the future, because it is a really interesting conversation that we can have. So again, thank you, Deb. I really appreciate it. Thank you everyone for watching, and we'll see you for the next episode of Emergency Cooking. Bye.